All right. Hello again. Welcome to another Down Fractured podcast, a podcast for talking jaws. Um, Basic housekeeping as always. Feel free to email the podcast at downfracturedpodcast@gmail.com. The fan mail is interesting, but we would also like some input into cases, questions, topics, for suggestion of what you all would feel interested in hearing about. Per usual as well, I'm here with Dr. Sam Bobek. This is Dr. Michael Wasson. How's it going, Sam? Do you have a good weekend?
It was great. I had a volleyball tournament I attended for most of the day, so
Oh, no,
I
you
learned
played.
about volleyball.
Oh, okay. And then we have a special guest here today, right? Do you want to tell
Yeah,
us about our
absolutely. Yeah.
guest?
So today we have another guest, but it's a physical therapist that I work with. So Hope Evans is with us. She works here in the Seattle metro area. She works in this practice called Select Physical Therapy and has a special interest in TMD. And so she's, I think, in charge of that aspect of the clinic. Am I wrong in that, Hope?
Yeah, been training our Kirkland and Bothell clinic, and we actually just started training Washington State as a whole. We have 14 other clinics in our TMD program, and then our Oregon market as well. We have four, like outside of Portland.
Got it. So you're the person to talk to for physical therapy for TMJ.
Yes. I wanted
Perfect.
to ask, did they win the tournament? You left that part out.
No, they did the absolute opposite. It was on the
Ah,
other side of that, which is, they're it was a middle school kind of level, so they're kind of figuring it out. So it's good.
riveting.
Well, I mean, yeah, I still have a lot to learn with volleyball. So there's a lot of stuff happening that I don't understand. So I learned a lot yesterday. Well, yeah, but thanks for coming on. Because I just Hope joined me in the operating room not all that long ago. I had a goofy case, but she was nice to sit through it. I was a TMJ replacement patient, and I know we've worked together on different things, and so I like just kind of jumping in on the topic in terms of physical therapy. From your perspective, for TMJ patients, who's the ones that you like to see at the beginning versus after surgery? So, what's your take on that?
I would say pre-operatively, especially the TJRs or just people with a lot going on, it's nice to kind of have that baseline education just to get them kind of prepped for their expectation going into surgery. Um, and arthroscopy as well, just because sometimes I feel like the patient's perception of pain and outcomes and function can kind of be a little bit hard to clean up on the back end. So seeing those before would
So,
be
do you
awesome.
develop a relationship with them, or do they just like become part of the program? Like, how does that work when you're like the initial intake visit with Hope?
It's definitely more relationship based. We get a full hour, and my minimum program is about 8 visits. So I get to spend 8 hours with the person,
Okay.
more or less. So I think having them beforehand, kind of learning what their work life is like, their stress life is like, just because there's so many other aspects that kind of lead into the TMD, kind of helps me prep them for, okay, so surgery is going to fix this piece of it. How do we fix the other pieces of it? And then prep for the post-operative part of it. Does that make
If some,
sense?
yeah, totally. If someone's like on the fence of surgery or they're still got a few weeks or a few months for surgery and we have them come see you, because I mean, the way I do it is I try to have them see you before surgery just to kind of meet and make sure that's arranged for that they aren't trying to figure that out after surgery. Um,
Yes.
is there things that you give them to maybe get them better without surgery? Do you like say, hey, let's plan for surgery, but here's two or three things I want you to try to see if you get better with.
Yeah, usually on that first day, just with the examination, I can kind of see what part the muscle actually plays a piece in it because obviously they have some sort of joint issue if they're going in for surgery. But I do like a test retest basis. So if I can change the range of motion X amount just with soft tissue, I can be like, okay, so your expectation for pre-op is this much range. And depending on functionally how you feel with that, if you're happy with that, that's great. If you need more, surgery is the option from a muscle perspective. And then a lot of times there's like a motor control deficit and just like proprioceptive movement issue too. So I
Yeah.
kind of teach them just your typical rotational opening, but also kind of grade the exposure to load if they're having issues with chewing or talking, etc., prior to surgery. And if they do well, usually it's 4 weeks and I could tell them if that's where they want to be. But surgery might be the next step if that's not where they're happy at.
Got it. Because I mean, like, I have a different opinion than Wasson. I like people getting off the surgery route. I like them getting better with just PT alone. And I think people like more myogenous or more like proprioceptive probably do better, right? Or no?
Absolutely, absolutely. I think the hardest part in that is if there's a psych component, a stress component, but if we can at least talk through that in my evaluation, and I also have another like pain psychologist that works with them sometimes too. Sometimes that can be the whole case, but
Yeah, that sounds cool. Wasson, what's it like in Arizona?
I go about it differently, as you know.
I love it.
Different strokes for different folks. And I
Yeah.
mean, if you want some more, old man kind of Southern sayings, Sam, here's one for you. There are many different ways to skin a cat. Have you heard that one?
I have heard that one. Yeah, that
Okay, good.
yes,
All
sir.
right.
you think more
Um,
about that, it gets worse.
yeah, yeah, I don't know. Yeah, maybe. Yeah, my mind's going places it shouldn't right now. But yeah, I mean, I guess I would just say from a perspective of this podcast education, I do go about it completely different. I have a good physical therapist here that I have a good relationship with that gets good outcomes results. So I'm lucky, just like I'm lucky in, last week's guest and having a good oral facial pain group. But I go about it differently in the sense that I almost either I hate to be like black and white or like put things in a like algorithm or anything like that, but I kind of use physical therapy as a way to either see if we can avoid surgery, like you guys were both saying there, like, hey, can I send them and see if this gets them to a place where they're content? And if so, then maybe we postpone or don't do surgery. Or I utilize it really if the patient's not doing well on their own. So like for TMJR, so TMJ total joint replacement, Sam and I have had this discussion. If I give them an Aura Stretch, a Therabyte, or whatever tool, and give them a little bit of my own program, and I'm following them and they're doing well and continuing to improve, then I don't really involve physical therapy. If I feel like they're struggling, or the common refrain I give them is, at some point you're going to plateau, and if you're not happy with that point, then we do need to get you to physical therapy. So I don't really do the pre-surgical physical therapy route, but hearing you guys talk, it seems like there may be some benefit to that. But my approach has always been like, let me spare you that time and possible expense, although it's probably, covered by health insurance and not too big of a deal. But I guess my philosophy and approach has just been different, but maybe I'm wrong in that regard.
No, I mean, I know of a number of people that have the same practice pattern as you do, which is not a guarantee to need physical therapy post TJR. Which is a little bit how we manage jaw rehab after orthognathic surgery, right? Like, I mean,
Yep.
I definitely practice that way after orthognathics, just because we do a lot of things to limit mobility, and we're kind of focusing on other aspects of recovery before movement. And so if they don't do well with my kind of general stretching routine, then I send orthognathic patients off to physical therapy. Um, I try to practice a little bit more like orthopedic surgeon in terms of the joint work. I mean, Hope, what's it like in orthopedic world? Do you have this two different camps of surgeons, or are they all pretty much the same?
I'd say there's definitely two different camps. I think we have a little bit more research orthopedically too that
Yeah.
prehab does help. I also feel like with TJRs, they do, if it is traditionally a joint issue, they do very well without PT. I think sometimes maybe think of it as like an insurance thing where let's have a pre-op just in case if there's any other like psych or muscular stuff going on too. And then they're prepped for later. Just because I've had a couple on the back end where, and I know Sam will remember some of these, I feel like there was, you referred to it as their philosophy of life, and their philosophy of pain was a little bit not what we thought it was. And so then you're dealing with that aftermath versus maybe if that conversation is before, maybe that kind of helps the outcomes. But I'd say 9 times out of 10, that makes sense.
Can do you think you can gain lateral excursive with TGR? Hope, you think
Yeah.
we can teach people lateral excursive motion?
Yeah. One of my PTs, I actually just talked to her yesterday. She had 3 this summer, and they each got up to 5 millimeters. I've had one that had full 10. I mean, we worked for it, but you can.
What are you doing to get people lateral excursive movements after TTR?
I almost treat it like a palsy. Like I do treat Bell's palsy and kind of facial nerve paralysis after, and it's more of a proprioceptive thing in the beginning, and they get so frustrated with me. But I'm like, you have to think that you're doing it, and I'll have like a tongue depressor cue so their brain kind of knows where midline is. I'll even have them like add some light overpressure if they're post 3 weeks, and it's just repeated, and I have them do it every couple hours for a couple weeks, but it works. Um, I know that I don't know what's causing it just because everything is cut essentially, but I do know the body finds a way with that.
Yeah, I mean, I definitely have an impression that because conventional wisdom is that you don't gain any lateral excursive movement, but I don't know. In practice, it seems like people can gain reasonable side to side motion.
Yes.
So
With a lot of effort, but yes.
yeah,
No, that's you guys are this is bad. You don't want to do that.
it seems like motivated patients are the ones that have that happen. But what's wrong with side to side motion, Wasson? What's wrong with that?
Well, I mean, man, I don't, this is where we run the risk of getting out of the weeds here. But I mean, so a couple things. One would be, do you think that there's benefit to that? I mean, like, it's one of those questions when you ask it, it's almost like, what is this guy talking about? Like, of course we'd want side to side motion, but like, what are they really gaining by being able to do that? I mean, and the second part of it would be, do we want them to? I mean, the prosthetics are not necessarily fabricated to have that manner of movement on them, and I would be worried about long-term wear properties being worse in
Well,
that
no, I think they're
scenario
fabricated for
versus.
that, aren't they? I mean, because it's a flat articulating surface. It's not a concave articulating surface. Like the fossa is flat. I mean, and I interpret it to be flat to allow for some wiggle in the placement of the condyles, but also for movement, right?
I don't know. I mean, it is kind of a ball in a cup, and I guess you could make the argument of the cup is all somewhat fabricated the same, and it's not necessarily a bad thing, but I would have some concerns over that, and I don't know if we have an answer to that question. Maybe that's a question for another forum.
Oh, sure. But I mean, I generally think of lateral excursive as more like a talking and like a chewing jaw motion. And people don't seem to care too much about how wide they open their mouth. I mean, some people definitely care, but they generally care about how they can use their mouth in normal daily activities. And I mean, I don't know, it's nice to kind of maintain that if they can. I mean, do you Hope, what's it like in terms of overlap with jaw physical therapy and speech, like speech therapy? Like how do those two
I,
worlds meet up?
I was gonna backtrack for a second too, and I feel like just with the lateral excursion patient, like that's one of their biggest complaints, and just that like feeling of normalcy with those functional movements, even 4 or 5 millimeters makes a huge difference too.
Oh,
Not
so they're
sure.
You,
telling you that they feel restricted, like they notice that?
Yes. Yeah, just like you said, in chewing and other like daily activities, just that's a big complaint of theirs. So I feel like maybe being cautious in that, but I don't know. Until we have the long-term evidence, I'm not sure.
And can you
I think
get
it's
any
kind of
protrusive since we're talking about it? What do you think about protrusive movements? You think you can gain that or no?
Protrudes, I've seen like 1 millimeter maybe, but it's not something I feel like we focus more on lateral excursion. We see what we get with protrusion in the first like 4 to 6 weeks, and if it doesn't happen, it doesn't happen. But I think being able to tell them that before they have the surgery does help too, just so they kind of have that expectation.
You know, Watson, Hope's making some good points. Are
it
you
is.
are you leaning towards it or what do you think?
I would want to inquire about the wear properties. I mean, you're probably right, but it is a little bit of a hesitancy. And
Yeah,
I was
sure.
just going to point out that it's absolutely interesting, and we all know this if you practice for any amount of time. What patients will tell you, Hope, and your maybe in your world versus what they tell us, because some of those things I'm like, well, they don't really seem to complain about them to me, and I kind of got that impression from you too, Sam. But
Mhm.
is that the case? Am I speaking incorrectly for you?
Well, I'm actually more on board with trying to get side to side motion. I mean, I kind of disagree with the idea of resuspending the lateral pterygoid. I know there's some different surgical opinions on that, but it's largely based out of I feel like you can get good rehab for side to side motion. And I mean, protrusive motion, I'm in agreement with Hope, and I don't think I've ever seen that post op, but I've seen some really good side to side motion, but it's people who are kind of engaged and really motivated to regain it. I've had on a handful of occasions, in unilateral cases, people point out the asymmetric opening and it bugs them. You know, like
Oh yeah,
a
that
left
for
side of
sure.
TGR, and then their maximal opening deflects towards the replacement device.
Prosthetic, yeah.
Um, and so, you know, PT to kind of help that out, and also to hear from a different person. I like that a lot too. I mean, I feel like that's solid.
Yeah. I mean, we're certainly not equipped to deal with that day to day. I mean, just the way our practices are, just like we were kind of talking about with oral facial pain last week, is like we're not equipped to see every patient, diagnose them, and then get them to the right place. Like,
Yeah. All right. So hope
That's
in terms
where
of speech therapy, what do you think? When should we point them towards speech therapy, or do people just get better at that with physical therapy?
I feel like I don't have to send them a lot. A lot of times, like over time with the post-op and a lot of just the facial nerve, if you have any issues with that healing or just rehab in general, they get better. There's occasional, um, I feel like that's more with like tongue tie issues or other things like that. So not much that I've seen.
So in your practice, do you feel like, because there's got to be some overlap, right? I mean, there has
To
to
a
be.
point, we have to be careful. So I'm only allowed to like, it's like the funny nuances they have where I can practice rotational opening with them and like tongue position and tongue muscle activation, but no sound, no like swallowing exercises, none of that. So I feel like from orthognathic and TGR and all that, I've never had to refer, but I do see a lot of post-cancer and like other like of those cases where I do. But
Okay. So on the speech side, they can't do the stretching exercises, but they can do the sounds and that sort of thing.
yep, yep. Sounds, swallowing, and some more of like the tongue positioning stuff, but that's about it.
Got it. Uh,
Yeah, I
yeah,
feel
no,
like
that's helpful
just
for me
free
to know.
fibular flap is like the main ones that I've sent for speech.
Yeah, it's pretty different recovery
Yeah.
process in terms of that.
Mhm.
Now, Hope, I think the other ones that, because I work with some other different physical therapists, and you work with some other surgeons, and
Mhm.
I get the request of like what regimen do you want these patients on? Like, can you give me a sheet of paper to tell me what these patients need to do? In terms of seeing patients from surgeons, do you like having a very scripted instruction, or would you rather have like leeway to do the right thing? Like pros and cons of that.
I think a little bit of both. I like to know, especially like orthognathic or TGR, like if you have any specific preferences on when to add overpressure versus light overpressure. Our general is like 3 weeks post. You can start light stuff. Um, But yeah, and then I'd say regimen wise, I do actually have my sheets and stuff. They get a little bit more nuanced in when I'm educating the patient on how to progress, regress. But I know we talked about making like a TMJ or post-op for dummies thing.
Yeah.
You do have resources like that that we go through too.
So it sounds like you kind of like your plan. And if you had a surgeon send you a bunch of things, that's not necessarily offensive.
Not necessarily offensive. I think I like to hear what your thoughts are, especially like in the healing process. I feel like I've inherited a lot of patients from other PTs or like other oral facial like pain specialists where they jump the gun too quickly and like don't really take the mechanical um graded exposure route, and so they're just upset with their like outcome. So I feel like we break it down a little bit more piece by piece, and that's where it's kind of made the program a little bit more efficient.
You're throwing down some physical therapy term there. You said mechanical gradated response. Is that what you said?
Yeah, so basically,
What's that?
our program is based on like the mechanical, like rotational opening first, and then we start adding the protrusion and lateral excursion, but it's kind of in their certain pain window. I feel like a lot of people are like, oh, just do 20 times as far as you can. And sometimes that kicks them into an inflammatory process versus kind of teaching them where that mid-grade piece is. Um, does that clear it up a little bit?
Yeah, I think so. I just
Mhm.
sorry, I didn't know that term, so I was just trying to keep up is all. Um Wasson, what are you thinking?
I think it's all good stuff. And you mentioned some time points there and how they might still be in like a, you might either exacerbate or initiate an inflammatory reaction, depending on their time
Mhm.
point of healing. And those are always questions that I have, and maybe you can kind of give us some rough time points. We know every patient's different, the procedure is different, age is different, their pain tolerance is different. But are there time points that you like beyond what you just mentioned, for certain procedures to where you feel like maybe we send them too early, too late? Feel like, do we send them at a point and you're like, what do you want me to do? I can't do anything with this patient right now. Like, why are we wasting everyone's time? I'm going to guess that maybe that answer is no, since you guys tend to kind of do a pre-assessment. But I guess, can you speak to that for maybe those of us that don't go that route?
Yeah, I would say usually if you're doing orthognathic, like 4 to 6 weeks post, I feel like is a good touch point. Sometimes I might not be able to do a lot with them if they don't have a lot of muscular restriction or any kind of like internal derangement, irritation going on. But I think it's a good time to start the relationship if we didn't do a pre-op. And then I actually, a couple of our orthognathics this year, I started doing more. So just like a monthly check-in with them. Um, but yeah, I would say 4 to 6 weeks post the more intensive, and then arthroscopy and arthrocentesis, like 1 to 2 weeks right after is totally fine.
Okay. What about for total joint replacement? Do you
I
kind of
would
do that
say
as the same as orthognathic?
I would say about the same as orthognathic, maybe even a little bit earlier, just because if we can get on that rotational opening program and just see how everything is healing up, that can be helpful too. But
Now, when you see Sam's cases from these time points, like, is it more difficult, like, because about 90% of them can't move their face at all? Does that create new challenges, or is that just something that you guys are easily to work through?
I think, yes, it's difficult in that extent, but that's also like where I can help. That's kind of when we start that proprioceptive piece. And if I can talk to them before and be like, hey, you're not gonna be able to move your face after. Sometimes that kind of helps the buy-in.
I would just like to
Um,
Right.
clarify that everyone gets paid here.
I wasn't even talking about your TJR. I was talking about your orthognathics.
Yeah, yeah. Full face.
hey, it all heals, and sometimes it heals at different times. But
That's
Uh,
true.
yeah. So Hope. So how much are you doing remote? Like how many remote visits are you following up with these guys? Are they all in person or what's it like for a patient?
I did way more remote, like right after COVID. I probably only had 2 remote patients this year, but I mean, during COVID or like early 2022, I probably had like 2 or 3 a month that I was doing. And we wouldn't do solely remote if we could. Like I would have an in-person, we do 2 remote, and then we'd have another one in person and just kind of stagger so they don't have to come in. Um, but yeah.
And so
So
when we sent like when I sign someone up or they're like, hey, you have to do physical therapy, there's the hour intake visit, and then they stop by. I have an impression that they stop by once a week. Depends on the person, obviously.
Mhm.
But like generally, what are we signing patients up for? Like 2 months, 2 weeks, 3 visits. Give me a ballpark kind of so I understand from the patient side.
Depending on surgery, and I would say if it's more of like internal derangement, like arthroscopy, arthrocentesis, I like to see them twice a week, for 4 weeks, and that's usually like your quickest, best outcomes, and maybe like 1 or 2 follow-ups after that, which total of 8 to 9 visits, it's not bad. And then if it's orthognathic, I might see them that first initial 2 to 4 weeks, depending on what we're working with, and then we'll do like a monthly check-in after that.
Got it. And
so what
TGR
let me
is a couple months.
Mhm.
Yeah.
let
Go
me
ahead.
follow up on that if I can. So this is a question I often get from patients, and I have it to a degree myself. But what are you doing in person specifically that you can't necessarily do remote? Because I have had some patients come back and say that they've seen some physical therapists who have their hand in their mouth and are doing certain things at certain times, and I'm not sure what they're doing, or what the benefit is. So what are some of those things that are being done that you feel benefit you being seeing them face to face and in person?
For sure, with internal derangement, any kind of joint mobilization, that would be my biggest thing. And then everybody else, I tell them by your third or fourth visit or fourth week, you're going to learn how to do the internal soft tissue work that I teach you, that I'm doing on you. But the main thing would be the joint mobilization that they can't do themselves. But
Okay. What are you doing in their mouth?
uh,
Because that's like our territory, and I don't know that I'm cool with you being in there.
so are you talking which type of
Yeah, are
surgery?
you doing kind of soft tissue manipulation, massage,
Yes.
stretching? What
Mhm.
exactly are you doing? Can you go into a little more detail on that? Because I that's one of the things I'm kind of oblivious to,
Yeah, it
among
would be
many others.
yes, it would be soft tissue manipulation essentially. And then if you're doing a joint mobilization, it's just a little bit of distraction, kind of gapping of the joint too. I do because Therabite does work a lot of times, but sometimes patients struggle with it, and if it's a tougher case, it's gonna bend. So sometimes it's just actual overpressure where I'm adding the pressure that Therabite would, or I'll even teach them how to use like a stack of tongue depressors and kind of increase pressure for that too. So a lot of it more is the educational piece of what they can do soft tissue wise for themselves, because that's all something they can eventually do on their own. But they're pretty lost in there the first 2 or 3 visits, I would say.
Okay.
Oh, we've been harassing you. I feel like we're peppering you with questions. Can you pepper
I love it
Dr.
though.
Wasson with
It's all good.
questions? Can you just harass him about some crazy stuff that surgeons do?
I did, hold on. I wanted to know, because I know we all have the different PT experiences. What do you feel like PTs do wrong often, or like bad experiences with PTs?
Well, I mean, I think if we're really going to be honest with this, it's probably a lot easier to list the things they do right
Mhm.
than the things that they do wrong, because that's a much longer list.
You think so?
Uh, I'm kidding. Come on.
So
Okay.
we can
Yeah.
do
No, I was
both.
like, gee.
Have you been on our
Just both.
show? No, I mean, to be candid, I've had some people see some physical therapists that I didn't send them to, I didn't know anything about, and they just mentioned some stuff that they're doing, and I'm like, you never want to throw anyone under the bus. You never want to come across as like I've got it all figured out, and there's no way that this person could be doing something that's correct that I don't know about it. But they have come back and I can't honestly think of what the specifics are. They've just said some strange things, and I'm like, that just seems a little bit odd. And
Yes.
so, but I don't know. Like maybe it's you try conventional first, just like all of us. You try conventional first, and if conventional doesn't work, you go to unconventional. Um, so I don't necessarily have an inherent problem. And like I said before, I just like you, Sam, I have my person or people that I try to get them to, and so most of the time, I think that alone avoids a lot of the negatives. I mean, it's somewhat at some point it's a results oriented business, right? Like if you're doing weird stuff and you get a good result, then maybe we should be doing more weird stuff.
Yeah, because I mean, I think probably mine is that they go to a place that's not all that comfortable with TMJ or TMD. And, it seems like it's all posture work. And I'm not
Hmm.
not against posture work. It's just, I hear back from patients, it's like, well, I went to this place and we just spent all the time on head position and,
Neck and shoulders and yep.
yeah, and I understand there's a connection. It's just, is that a marker of someone who may not have as much experience with TMJ therapy, or is there just like a different philosophy in terms of physical therapy with posture?
I could say it's definitely a marker. I feel like sometimes they get those cases, and that's what we learned in school. And I mean, I do have them on a posture program just preemptively, but a lot of the ones I inherit, it's like, oh, they didn't even work externally or intraorally. It was all just neck and head positioning. It's like, okay, so yes, that can contribute, but typically not the main cause. So
So
yeah,
how do you
I would
find
say
people who have experience with TMJ physical therapy? Like, is there's not
Yeah,
like, because you go on their website and it's, like, how do you
it's
figure that out?
listed. Yep. Great question.
I say out here, I trained them. I've ran into, I think maybe two others that seem to have like similar philosophy, but I run into a lot more where like patients that have seen somebody else first that they just like are taking a whack at it and they don't have like experience with that.
But I mean,
But
is it is it a common screening thing and the front desk? Like if you're a patient or if, like we have our office call someone and they say, hey, do you guys see TMJ physical therapy? Is that an offensive question?
It's
Like,
not offensive. I would ask before you refer, honestly. Just ask the front desk too. Because we have in our market before everyone was trained, it was like, no, but X, Y, and Z offices do. And those are all people that have been seeing them for a couple of years and are like confident in it. Just because a good clinic should know like when it's their specialty versus when they should find someone else.
yeah, because how
But
many subspecialties of physical therapy are there? Is there like 20,
so so many.
50,
And I feel
50?
like they're expanding, but
There's a
it's
lot.
just and TMD isn't standardized. Like we get maybe a 2 hour lecture in school. That's it. It's all just like
Sounds
continued.
like dental school.
It does sound like dental school.
I've heard that.
It's
I've heard
crazy.
that. Um, but yeah, it's a lot of it's just like experience in the field and like mentorship from other people. But
Got it. So what got you interested in TMJ stuff?
it was completely accidental, not intentional. I'm more into orthopedics and sports, but to get hired for my Kirkland job, one of the PTs was just starting to dabble in it. She had, I think, 4 or 5 just general, like internal derangement patients, and she taught me what she knew and that she had learned from her mentor. And I actually had been diagnosed with post-concussive syndrome from college soccer, and my headaches slash everything was actually from my own TMD. And then my husband actually had migraines that came from his too. And so we actually met with one of the surgeons next door and just started like going through research and asking questions and kind of started the relationship from there. But
Nice.
yeah.
Yeah. So is there a trend towards doing more of that? Like, in your perspective, like in the National Physical Therapy meeting, whatever, I assume there's some American Academy of Physical Therapy and there's national meetings. Is there an increasing interest in TMD stuff or is it still kind of like hit
I
or
would say it was slow, but I would say the past year or so, I've been surprised and like happy with there being more interest. Like we had a contractor actually come like looking to work for us because he had interested in learning TMD. And then a lot of like students that are coming out are like, oh, we heard you specialize in TMD. We want to learn. Like our professors say we need mentorship in that. So I feel like they're looking for it more versus 4 or 5 years ago. Like I remember the lecturer came in and we were like, what are we doing? This is for dentists, sort of thing.
yeah,
But I feel like they're slowly getting some more controlled trials, not great ones, but evidence out there. And I think just the conversation is getting better, at least.
it's good to hear.
But
One day it'll
yeah.
get to Arizona.
Yeah, I was gonna ask, is Arizona direct access, Dr. Watson?
Oh man, you're asking me these questions. I think so, just by the nature of my conversations, but I haven't had that specific discussion, but I think so. Um,
I didn't know if that
Based
played a
on
part in it too, but
Yeah, because I mean, the physical therapist that I work with is constantly mentioning how a lot of his referrals are, direct from other patients and other things. So
gotcha.
I don't know. I think they can, but at the same time, I do have to constantly update referrals and stuff like that. So I don't know. That's a good question. Maybe I should ask to have a better understanding. Um, can I take this
What do you
another
like about
direction?
your, oh, sorry. I was gonna ask, what do you like about your PT? What does he do?
Well, one, communication is
Mhm.
easy and nice. He's a cool guy. Like he's someone that, I would, there's some people who are good at what they do, but you kind of are like putting your hand in your palm and saying, "Oh, gotta talk to so and so." We all have those, and I'm sure I'm that person to a number of people, right? It goes both ways. And so communication is nice. He's enthusiastic. He's personable for the patients as well, and has a lot of experience. Been doing it
Mhm.
for a long time. Decades here in the Valley. Has worked with a number of surgeons, a number of oral pain specialists, dentists, you name it. So I learn stuff from him just like I think he learns from me. And so to me, that's what makes it a positive experience for the patients as well.
Watson, you were going to go a different direction.
Yeah, I just, one thing that you may not have it, and I don't mean to put you on the spot. Well, I mean, I do mean to put you on the spot. You came on the show. But do you have any like
Sorry.
tricks, tidbits? We kind of were mentioning it earlier, but like is there like a little trick that you notice, hey, if patients really aren't progressing like you think they should, is there a technique? Is there a set of verbiage? Is there motivational tricks that you have that you could share with us that maybe we could utilize in our patients in our practice? And if you think of it from the perspective of continuity, it's always nice when patients hear a similar message or the same message from multiple providers. And I think that's both reassuring and eliminates confusion. Do you have any of those? And if not, why?
Yeah. You say verbiage. I feel like the one that always comes back to me where they're like, yes, this was different and this helped. We use a stoplight system, like when we're teaching our phases of rehab. It's actually kind of based off of, I have a little bit of background in mechanical diagnosis and therapy. And so they use when you're grading exposure, that was the word we used earlier. So kind of like slowly increasing load without over increasing it. You use the stoplight theory. So when I'm getting them into like protrusion or lateral excursion, a lot of times I've inherited patients where they're just jamming into it. They're just trying to go full end range. And I teach them, okay, so when you're learning this, it's a yellow light, red light rule. So yellow is it's a little achy, a little nasty, but it's not getting any worse. Stay in your yellow zone. If you go too far and it's sharp, stabby, you're popping, that's a red. And just staying in that yellow zone will get farther if you stick with these. And then we have like all our parameters, like how often you do it during the day. And then sometimes you'll have delayed symptoms where, say, they do get headaches, even though they were in said yellow zone. So that's labeled as a red zone. So not to get like super into the weeds with that, but we kind of use that progressive overloading concept that you would use for a knee or an ankle or a back, but keep it in said zones. And that makes it easier for the patient to understand.
I like it.
Is that helpful or confusing?
Yeah, it is. No, I think it is helpful. I like it. Sam had a scowl on his face, or
No, no,
did
no.
you
I
not
was
like it?
just it was good. I think in terms of that stuff is the reason why I like them talking to you about that. I think that's great. I
It
think
takes time.
Right.
That's the problem.
yes, because I could get in the weeds and that stuff, and I think it's easier to have another person talk about the weeds. So
Mhm.
yeah, I think
Say,
the PT talk's good. Can I what do you think really about therabites? Are they useful or not that useful?
uh, do you want honest opinion?
Yeah.
They're too freaking expensive.
They're too
Just for a lot
expensive.
of
All right.
them.
So in my neck of the woods, we have a cheater therabite of a clothing pin, a wooden clothing pin with glued um popsicle sticks on either end, tongue depressors. You think that is on the other extreme, like too cheap?
Oh,
Is there a middle
I'm
ground?
sounds like I'm from the same neck of the woods. But we actually
Are
we
you
do
familiar with Neck of the Woods, Sam?
What's that?
Are you familiar with Neck of the Woods? Is that
Yeah,
another
I've
old
heard
man
that
saying you
saying.
don't
Yeah,
know?
yeah, Illinois, right? That's where the woods are.
yeah. But so is there a middle ground that's the ideal there, or is it like because
So
what do you think?
sorry.
No, go ahead.
I don't do the clothespin thing. I have a stack of tongue depressors and I have them on a timer. And then as it opens more, I have them add another tongue depressor. And like objectively, we just keep track of how many to add. Um, and we go from there. But I feel like financially for them, and they also always say just because it like is completely on like their occlusal area too, it just is easier for them, feels better. Um, yeah, that was basically how we go about it.
Got it. My other PT thing that I was wondering, you've seen jaw strengthening devices? Like there's the goofy jaw exerciser and like different ways
Yes.
that people strengthen their jaw muscles for more like chiseled face and whatnot. But in
What are your
terms of
thoughts on those?
strengthening muscle as part of their rehab, what muscles do you work on when it comes to that?
So I do less like specific muscle, I do more directional. So when they can fully, and this is kind of the phases we talked about, when they can reach full protrusion, lateral excursion, or if they're plateaued for 2 weeks, we start adding internal external resistance. But we do all three directions. So they'll do external protrusion with overpressure, but keeping it like in that yellow light zone. They'll do it outside, yellow light, and then internal. I'll actually have them use vinyl tubing and they essentially compress in load through those three ranges, but we have to be careful with that because that can really, really kick into the red zone. So I kind of, if I'm trying to strengthen them to get back on like a hard chewing program, I let them use that to kind of build up towards that. But I never am like, oh, you're strengthening master, or you're strengthening temporalis. It's just like you're strengthening these three directions because that's your kind of functional chewing movement that we're progressing to.
Got it. So you're strengthening functions rather than the individual muscle belly or anything.
Yes. And just easier for them to understand too versus breaking that down. But
Sure. I feel like I've learned a ton about PT. I feel like this is a good conversation.
awesome.
Watson, you got anything?
I was thinking of some things, and I don't know that you'd be able to answer this. I had kind of two things that I was wondering about, but like, Sam, when you refer, do you indicate whether or not you've done like coronoidectomies or not? I'm
No,
guessing you don't, right? Okay.
no.
Because that would have been one of my questions is do you see any difference in how the post-operative course from a physical therapy perspective goes between that subset of patients who have or have not had coronoidectomies? But that's a tough one to kind of answer, I think.
I Yeah, I don't know the answer to that one. I wanted to
Yeah.
actually ask your opinion on, well, I feel like I kind of know because I've seen condylectomies like in the past too. And I wanted your thoughts on coronoidectomies, condylectomies, and
Yeah, so I mean, so I just wanted to make sure I'm talking about the same thing that you're talking about. So
Mm.
condylectomy is used in different situations. In terms of the treatment of internal derangement condylectomy, or do you mean like post resection cancer condylectomy or
I would say internal
condylar
derangement.
hyperplasia? Like which one is
Mhm.
it?
The internal derangement, and then I've seen the hyperplasia too. I just feel like haven't seen them do well, and I just wanted your thoughts on outcomes with all that.
Well, so because this came up not all that long ago, right, Watson? Someone had asked about
Yeah.
the condylotomy in terms of that intervention. Do you understand like how that surgery goes, Hope?
Could
The
you
idea
refresh?
the idea is that you make a cut in the bone,
Can
in
you
the
see my
mandible
mouse
so that the
cursor?
condyle sags.
Hmm.
And the idea is that you have them in a period of IMF, and the condylar sag creates a better relationship of the disc and the condyle. And so it basically creates joint space by allowing for a condylar sag. And then you just rehab them after the fact. Um, is at least the theory on internal derangement. And I haven't practiced using that technique, and I was hoping to find someone who does that. Um, and Wasson at least knows of it, and I feel like he has some experience of doing it, but he left the talk just because he didn't want to
Didn't want
answer
to talk
any
about it.
questions about it, which I understand. I use condylectomy in terms
Aw.
of condylar hyperplasia patients, but that's kind of a different operation because the disc is repositioned um, over the condyle, and it's more like an open arthroplasty type of surgery.
Gotcha. Okay. Yeah, I was just curious. It was a couple years ago, but it was just one of those I don't see very often, and outcomes were but
Yeah, I'm not super on board as that being part of the surgical algorithm,
mhm.
but I'm open to alternative ideas. Watson, what do you think? Am I missing some tidbits on how to do that?
No, I mean, I was just trying to, I kind of got sidetracked because of this small child
Ah,
here, but
Is this Mini Wasson?
it is. This is my little clone. But yeah, I
Oh,
tried to draw this blue line. I don't know if it's showing up, but if you just imagine there wasn't a prosthetic there and the condyle was there, like Sam was saying, you basically try to stay behind the nerve, which is, you see in the canal here, and you're cutting and separating that segment from the rest of the jaw, and you're trying to get condylar sag so that
mhm.
the segment that you cut moves down. And the reports are that that can even reduce discs or eliminate a lot of the TMJ symptoms. But in the context of physical therapy, I think it's kind of interesting because I don't, that's something I can't speak too much either, Sam, of like, how is their function afterwards? The few that I've been involved in, I felt like it was reasonable, but I don't know that I have the volume to say I have a good grasp on it either. Um, yeah.
from your view, Hope, it's not necessarily slam dunk wonderful thing.
No, and I wish so. It was like my first year I saw them too. I wish I like remembered better too, but I just remember the outcomes weren't ideal.
Because I mean, what that kind of reminds me of is I think something we talked about, so I think I know your answer to this, but in terms of trauma, right? So condyle
Mm.
fractures and fracture dislocations where people are treated closed and then they're told just go to rehab. It's like
Hmm.
just go see Hope, she'll fix all your problems. How do you feel about that?
I do not. I do not in that case.
Yeah, because I mean, there's some utility in having a condyle in the fossa there, right? Like, I mean, the rehab,
Hmm.
if they're treated to where the dislocation is reduced, is better. I know
Hmm.
that sounds silly. Do you think that's true, or do you think they basically do the same no matter what we do?
No, I completely agree with you in that regard. And that's what I wanted to ask. I remembered this might have been on your TJR podcast, but even in youth, like you talked about TJR being an option for that.
Yeah.
Or condylar fractures, is that what you're saying?
Yeah, or just upper.
Well,
Yeah.
so in terms of, I just increasingly think that having some reasonable relationship of the condyle to the fossa is useful in the post-traumatic treatment or
Mhm.
post-traumatic rehab, sorry. And so, literature is pretty clear that they rehab quicker and they get to their endpoint in a more like patient-friendly way with an open reduction of a condyle fracture. But there's some people that just, have very comminuted condyles or have such a small segment that you can't operate on. Um, I think that segment, I'm not sure if it's quite mainstream yet to do TJR as the primary operation. I think we still send them to rehab to see if they'll get better. Um, but I think in the future, using TJR in that situation is reasonable. Um,
Yeah, I mean, it makes
Yeah.
sense.
Yeah, I would just again because our audience may be, vast. We know it's vast but maybe coming from different backgrounds. I would say I agree with you, Sam, but another way of explaining that maybe so that there is wider understanding is yes, all of our, not all, but the majority of our research is trending towards open reduction, internal fixation of condylar subcondylar fractures actually yields better outcomes. The trade-off is the risk component that is thrown in there. But the surprising one, it's they do better with mouth opening. They do better with future TMJ symptoms as best they can track. And then the surprising one, though, is that they actually have less pain. And you would think, subjecting them to an operation, they would have more pain. But
Mhm.
their pain kind of beyond that first few days after a surgery is less too. So I think if you extrapolate that data with the same data that we were talking about with our minimally invasive surgery talk of, hey, if we actually do arthroscopy and kind of get a mobile disc, they have better outcomes than if you just treat them with a non-reduced disc and try to manage pain, inflammation, mobility, all those things. So I think if you kind of extrapolate those two independent processes or facts, you would make the case of what you're saying, Sam, of like, hey, having a appropriate condyle fossa relationship as well as a disc fossa relationship would be a superior outcome to what is proposed with the modified condylotomy.
yeah,
Or
because
did
I
I
mean,
or did I just make it more confusing?
well, because this is one of those things that I think if you're an outside perspective on this stuff, what we're saying makes sense. Like it's almost like kind of silly that we're even saying it, which is, like if you had a fracture dislocation of your shoulder, it's not like you're kind of considering just rehabbing it. But and I think it's still conventional wisdom in a lot of training programs to be taught
Oh,
to be taught
absolutely.
that a period of IMF and rehab will get you to the same spot as reducing a condylar fracture surgically and then rehabbing. So
Mhm.
I don't
Agreed.
know if you
Yeah,
know,
absolutely.
like Hope from there isn't just like an absolute standard still on how to manage these things. So when you see patients come in, it's likely just different training from different practitioners. So
Yeah.
Well, that's interesting to note that from your perspective, you also view it as outcomes being superior
Mhm.
if the condyles in the fossa, because sometimes I think our own profession, Sam, looks at people like us and who does these things and they say, as you're saying, that's still the way to treat them is closed reduction.
Yeah, it's wild.
And then
I mean,
you treat them closed and you get what you get is essentially the philosophy. You rehab them, you do what you do the best you can, but you get what you get, and that's the solution.
yeah, you just let it heal, dislocate it, and then you do a sag down the road. It's wild.
It is
Anyway,
wild. We're getting in the
well,
weeds
sweet. I
again.
think I was saying we're coming up on an hour. I feel like it's a long podcast. It's been a good one though. I feel like I've learned a lot of things from Hope.
Time flies when you're having fun. You heard that one?
Yeah. No, I know some
Never
old
heard
man
it.
sayings. I just you throwing out some curveballs from time to time.
Hitch in your get up. Have you
Yeah.
heard that one, Hope?
I have.
See, Sam?
But skinning cats, neck of the woods, hitching your get up. Where are you from?
Arkansas. Arkansas, then some time in Texas. So I got some, and now I'm down here in Arizona. Um, so yeah. Well, yeah, thanks, Hope. Sam, do you have anything else you were gonna add or say
No, I
there?
think that's it. I just appreciate you coming on, Hope. Yeah, and thanks for helping out with all the patients.
Yeah, thanks so much for having me.
Yeah, it's definitely good to kind of get the real life view of someone practicing in the world of TMJ care.
Yeah, jaw surgery. Well, yeah, thanks again. As always, it's been another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast at Gmail. If you want to send any suggestions or complain, those will probably be ignored, but you can. Topic suggestions, case suggestions, as always. And until next time, thanks for tuning in. See you, Sam.
All right, see you later.